was wondering if you could first tell us why you decided to enter the field of medicine.
Well, when I finished high school, I wanted to have a profession, and I applied to business school at University of Western Ontario, and I got my acceptance to secretarial science. Didn't want to be a secretary, so I got in touch with them, and they said, but they don't take women in business, nor do they take women in engineering. So if I wanted a profession, I had two choices, law or medicine. I didn't like to write, so I chose medicine. Had an interview, which was very interesting, because they said, what right did I think I had to go to medical school and keep a man out when I would practice for 5 years and quit, and he would practice for 40 years. So I told them that I didn't plan on being married, and I planned to work even if I did. Well, I got married Tuesday after we graduated on Saturday, but I practiced 40 years.
So you knew you were getting married, you just didn't tell them?
No, I didn't meet my husband until first year medical school. We were married when we graduated. One didn't get married in those days while you were going to medical, while you were going to college. It wasn't done. Yeah. So that there were a bunch of marriages in the week after graduation, before everybody started internship.
Yeah. Did you find it to be a struggle to
What?
just get an interview for medical school?
Oh, no. If you have good marks, you got an interview. In our class, there were 4 girls. Of a class of 60, it was the largest class they'd ever had. Usually there were 2. So there were 4 of us.
And where did you attend medical school?
I went to medical school at the University of Western Ontario in London, Canada. I graduated in 1956.
And from there, how did you decide to choose your specialty?
I went to medical school to become a pediatrician, and in those days, at least at Western, there was only rotating internship, so I did a rotating internship. Hated pediatrics, loved anesthesia, so I applied for an anesthesiology residency at Mass General because my husband had a fellowship in pharmacology at Harvard, and Mass General was the only hospital I knew in Boston, so I wrote them and they accepted me. But internship was very interesting in those days. We weren't as busy. They didn't have open heart procedures and things. And in London, there weren't shootings and knifings and things. They kept us reasonably busy. But the interns had a lot of scut work. For example, we started all the IVs. We did all the lab work at night. We worked every second night and every second weekend. So it was 36 hours on, 12 off for the year. You covered somebody else's floor when you were on call. And if any lab work had to be done at night, we did it. The intern in the emergency ward also did all the blood grouping and cross-matching. And I can remember once they had a ruptured aortic aneurysm in the OR, and I had to group and cross-match the blood. It was set up only to do 2 at a time. Not only did you have to do it, but you had to run it up to the floor, which is 2 or 3 floors up, without the benefit of elevators. Elevators, as usual, were too slow. And I really had trouble keeping ahead, but I do 2, run them up, come down, get 2 more, run them up. Did that for half the night. I'm still amazed that I didn't make a mistake, but there you had it. Living quarters were interesting, too, as an intern. They had redone the top floor of the hospital for on-call rooms for the docs. And I was the only female, of course, and they wouldn't let me there. And I pointed out that because there was only one big bathroom facility, I pointed out that the operating room was 1 floor down, and I could use the bathrooms down there, and they said, no, it wasn't done. My room was a half a block down the street. I don't know who else lived there because I only stayed there once. There's just, if you have to run for something a half a block away, especially in the winter, it's ridiculous. So since half the interns roughly were married and they weren't using their rooms, I used a different room every night when I was on call. Tried once sleeping with my husband in his room. That was ridiculous, with small beds, phone ringing all night. So I used somebody else's room. And that was okay for July, but August the housekeeper went on vacation, and they had somebody up there temporarily who saw me come out of a room one morning and looked at me askance, saw me come out of a different room another morning, looked at me again askance. The third morning she left her work and disappeared, I assumed to report, and I waited for the repercussions, which came about 11 months later before I left, when the hospital administrator met me in the hall and said, "By the way, Dr. Waud, if you had any duplicate keys made for the rooms in which you stayed, be sure to return them when you leave, won't you?" So I guess they knew about it all the time.
They never gave you too much of a hard time about it?
No, never heard about it until I left and they asked for the keys. You know, I suppose what they don't know, they can't be accused of getting into trouble with, so they just let it go. It was nice. It gave me a place to sleep. Applied to Mass General, as I said, when my husband was coming down to do pharmacology at Harvard. The first day there, one of the first nights I was on call, the Mass General was having a meeting of the new interns' wives. So I decided, I wasn't busy, I decided I'd go up and see what they had to say. And they started out, the guy who was talking started out by saying, "Before any of you complain about the pay," it was $25 a month, plus room and board, "I'll tell you right now that we could get in all the interns here that we wanted if we didn't pay them anything. So consider yourself lucky you're getting $25. At which point I was called back to the operating room and didn't hear the rest of the talk. The other thing is, one of the surgeons there said that I quote roughly now, that the trouble with today's residents is that many of them are married and their wives expect them home every second night and every second weekend. Before that, married residents weren't accepted, and if you were married or found out to be married during residency, you were booted out. At least in surgery. I don't know about medicine. So that was the atmosphere at the time there. I was paid as a resident, not an intern, my take-home pay, I think, was $66.33 a month. I had a room with still DC current that was beside the firehouse, which was down the street again. It had a cot and a chest of drawers. You could barely walk between them, but it didn't matter because there was no time when you were on call anyway to get any sleep, and if there was at 5 o'clock in the morning for a couple of hours, you slept on an operating table or in the pre-op room or something. The longest I ever worked was from 7 o'clock on Saturday morning until 7 o'clock on Monday night with 2 hours sleep. I got to bed at 5 o'clock Monday morning, was called at 7, why wasn't I in the operating room? I said my first case started at 10, and they said that didn't make any difference. So 2 hours sleep. That night, I can tell you how long ago it was. That night I was going home, subway of course, because there wasn't enough parking place, even if we could afford a car, which we couldn't. I gave my quarter to the person, got a token and a nickel, and couldn't figure out which one to put in the slot until somebody behind me said, "Put that in the slot," and pointed to the token. And I was back to work the next day, of course. Other than that, we were on call only every third night rather than every second, so we considered it a bargain.
Were there any other female residents or interns?
No.
You were the only one?
Yes.
Wow.
Yeah. Yes. Residency was rather different, and let me start at the beginning. First, with the anesthetic agents that we had were cyclopropane, nitrous oxide, and ether, diethyl ether. Cyclo and ether were both explosive. So no bulbies, it tied off things. Nitrous oxide, along with pentothal and muscle relaxants, was relatively new and frowned upon at Mass General. Pentothal had come out just prior to World War II, and a lot of people at Pearl Harbor died from pentothal. Anybody could give it. It was intravenous. But it's rather interesting because Beecher, who was chief of anesthesiology at the General and was a consultant or whatever to the war effort for anesthesia, had written an article that was published in Annals of Surgery about 1945, and he's talking now about anesthetics at the front, young, healthy guys who were bleeding. And there were a couple of things he said. First of all, that if the case took more than a half an hour, perhaps you should think about giving some oxygen along with the pentothal. So here you had an IV drug that anybody could use that was the only anesthetic. It depresses ventilation, it depresses a lot of other things too. But you weren't giving anything with it, not even oxygen, and it's not an analgesic. So the amount of pentothal you'd have to give to keep somebody was moving was tremendous. And it's no wonder that people died of it. The other thing Beecher said in that article was that IV fluids were dangerous. They'd go into congestive failure. So he said, if blood was available and somebody was bleeding, you gave them a unit of blood. If blood was not available, you gave them no more than 1 liter of saline. Now, young, healthy guys, 1 liter of saline? Because otherwise it was dangerous. Now, Beecher and Todd at the Mass General had done a study, muscle relaxants had just come out, and they'd done a study and determined that many more patients died following if they were given a muscle relaxant for their anesthetic than if they were not. Probably true, because we didn't reverse it. It was dangerous to reverse muscle relaxants until very recently. With the short-acting ones, muscle relaxants were always reversed. But they didn't know anything about kinetics, no computers. I mean, computers came out sometime in the early 60s, and then you could get distribution curves and all that, but nobody knew anything about that in the late 50s. The Beecher still thought, and many of the surgeons at the General thought, that pentothal and muscle relaxants were very, very dangerous. So you had explosive anesthetics, and that was it. It didn't matter because we didn't have EKGs. In the White Building, I think there were, I can't remember whether there were 10 or 12 rooms, but they had only 2 EKGs. They were called bullets. They were white things about lay long and face about like that, that you could have if you got there early enough in the morning and some staff person didn't steal it from you. To watch EKGs, probably that was okay. There were no ventilators. There was 1 ventilator for the whole 12 rooms, and the person who had the longest case that day got the ventilator. They weren't very good, but they were ventilators, and it gave you hands. So, if you're squeezing a bag with one hand and you're writing with another hand, how do you do all the other things you have to do? Well, for maybe half the cases at that time, patients were getting ether and breathing spontaneously. The concentration of ether, nobody knew. I mean, how do you know how deep your patient is? The Goodell's classification is for induction in somebody who's not medicated, and it doesn't mean anything when you're giving other drugs as well. Well, you sniffed it. So we became very adept at sniffing the concentration of ether and knowing just about what you needed for analgesia and just about what you needed if you needed some muscle relaxant. The ether came in bottles about that round and about that tall, and of course evaporation takes up heat, so you get caking of ice around, a frost around the bottle, so you'd have to keep changing them. And the soda lime canisters were about the same size, and they would get used up very quickly, so you had to keep changing them. The only monitor we had was blood pressure cuff. We took blood pressures and a finger on the pulse. That was it. And a hand on a bag. Now, what we did was use the tubing that normally went from the machine to the mask. We put that where the anesthetic bag normally went, put the bag at the other end, so you had a long tubing about like that, so that, and with the bag at the end of it, you could put it under your arm and do this. And if you needed both hands to do something, we put it on the floor, put the patient's chart on top of it, and yeah, you got it, and stamped on it. Were we giving adequate ventilation? Who knows? If the patient survived, I suppose we were. We had no blood gases, no way of measuring oxygen, either inspired or expired, no way of measuring carbon dioxide, inspired or expired, no way of measuring the concentration of gases we were giving. We could nitrous and cyclo, but not the others. And when ventilators came out, it was considered maybe a bad thing because you couldn't tell enough about the patient. It wasn't as good as the, quote, educated hand, unquote. That a hand on a bag could tell you whether the patient was trying to breathe and you could overtake it, or how well he was breathing if the patient was breathing spontaneously, or whether he was tight or whether he had enough muscle relaxant. We had no nerve stimulators. And for years, maybe even until I retired, if a resident or a nurse called me in the room and said they were having trouble, the first thing I did was turn off the ventilator and squeeze the bag to feel it. It really was a good thing. Whether it was as good as we thought it was is highly debatable, but we didn't have them. The endotracheal intubation was in its infancy, and when I did my rotation at the Children's Hospital, many of those children were not intubated at all. Tonsillectomies at that time were done with a patient sitting up with ether flowing through a hook in the mouth that went into the mouth. And with all that blood and gore going wherever it went, stomach, lungs, whatever, patients not breathing very well, try breathing with your mouth open and stuff in it. And I can remember once reaching under the drapes and trying to lift the patient's chin up, and the surgeon said, "Dearie, I was etherizing kids on the kitchen table before you were born. You just leave your hands out of this." So it was dangerous. By the time, when I finished my residency, we went to England for 3 years, and by the time I came back in '63, the younger surgeons were doing tonsillectomies with the patient lying down, head down. Still no endotracheal tubes. It was some years before tonsillectomies were done with endotracheal tubes. The surgeon said they couldn't do it. And I know of at least one hospital where they wanted anesthesiologists, got 2 of them, and they both refused to do anesthetics for tonsillectomies unless they were intubated. Now they're all intubated. The other thing at Children's Hospital was that they used ether or cyclo. Nothing else. Halothane was out by then, but they wouldn't allow it be used at the Children's Hospital, and this was maybe '59. And craniotomies were done with the patient, infants now, often sitting up, with drapes down over the table and down onto the floor. The person giving anesthesia was under these drapes, sitting beside the table on a stool, with a finger on a pulse, and unless it was quite an old child, no blood pressure cuff even. These patients were intubated, but they weren't intubated as we know it now. They had a Y piece. One end of the Y, the tail of the Y was hooked onto the endotracheal tube. One end of the Y was connected to tubing that went across the floor to the end of the floor to a bottle that held some ether that had air coming through it to vaporize the ether and get into the patient. The other end of the Y piece was where the patient exhaled. And if you wanted to control ventilation for any reason, you just put your finger over the end that it exhaled and closed it off for a minute to get breaths for the patient.
Could you control concentrations of ether with that?
My goodness, no. Maybe by the amount of oxygen you put through, but that was all. You could turn it off. Well, maybe a little bit. I don't remember that we really controlled it at all. But we were sitting under there for maybe 13 hours at a time, inhaling all this exhaled ether with the surgeons up in the head using a Bovie. And I can only assume it didn't explode more because it was air that was going through the ether, not oxygen. They did things like cleft palates and cleft lips with just an ether hook, no intubation. They said tubes got in the way. So that was, that was all right.
Did you see lots of pneumonias or anything like that from aspirating so much?
Well, with the tonsils, sometimes they even aspirated a tooth. You have to go down and get it out. Pneumonias, I don't really know that there were. When we, if a patient got into trouble or had difficulty breathing, or somebody thought the patient had difficulty breathing post-op, the patients were spread all over the hospital. It was up to the anesthesia resident on call to go up and do a bronchoscopy. Now, this was a rigid bronchoscopy with the patient in bed. You can't sedate them, and you can't use local anesthetics in case they vomited and aspirated, okay? So you have a patient here who's having difficulty breathing. You have no help. There's just you. Nurses often were too busy to be there. Here you were trying to do a rigid bronchoscopy in bed and suck out a plug. Now, I don't know what other years did, but I know our year, by the time our residency training was over, we weren't bronchoscoping people anymore because we discovered that it wasn't the bronchoscopy that did anything. It was making them cough. And you could make them cough just as easily by sticking just a suction catheter down their trachea, and that made life a lot easier. But during a rigid bronch. The other thing, that patients on ventilators, now they weren't post-op patients, they were patients with various degrees of muscle paralysis from other diseases, were spread all over the hospital, or all over the 3 hospitals. There were 3 buildings. If we were called, we had to, if somebody were anxious or something, we had to go up and check them out. And there was no way of knowing whether they were anxious just because they were anxious or whether they were hypoxic, because there was no way of measuring it. You had to go up and guess. They were, as I said, they were all over the hospital, and for order for us to go, we had to take an anesthetic machine with us. They weren't the big things we have now, but they had oxygen tanks on them and a tray on top, and they were not easy to move still. There was a passageway between the hospitals and only 1 floor, so you had to go down and across and up on other floors, all over the hospital. There were no ambues. Ambues came out perhaps, in late 50s, very late 50s. It was great. You didn't have to take a machine anymore. But the nurses that were looking after the patients often didn't know what was going on with the patients. I asked one once, is the patient intubated, and was told she didn't know. As it happened, the patient had a tracheostomy. But, here were the nurses that were supposed to know these things that didn't. Sometime around just around 1960, it was decided that maybe it would be a good idea to have patients who are on ventilators in the same hallway, at least, maybe in the same building, even if not in the same room, because then it would be easier to look after them, and the nurses looking after them and the residents running up wouldn't have to go all over the hospital. That was perhaps the start of ICUs. There was no closed chest massage for cardiac arrest. You opened them. And never mind where you were, you opened it. And often in the emergency room, you opened it, and then you squeezed until you took the patient up to the operating room, where you did whatever you did before you closed them up. They didn't survive very often. We got caught in an elevator once with somebody doing open chest massage, and the elevator wouldn't stop on the operating room floor. It would only stop at the basement or the roof. And so we had to go down to the basement and get the security to get all the visitors away from the elevator, so we could take this patient out of one elevator and into another to get up to the operating room to close. Well, we didn't give patients fluids. We did, however, give them blood. Blood was in bottles at the time. There was a rotator pump thing that you could use, but they didn't work very well. And the best way, if you wanted to infuse blood in a hurry, was to milk it down. Just hang on to one end and push it in. The IV tubing was rubber. It was not disposable. It was reused. they cleaned it, somebody cleaned it after it had been used. Once it was brought up to be used again, I don't know what crud was left inside the patient's cot, but that was how we did it. And that was when you used your foot to ventilate the patient as you were pumping in the blood.
And there were probably no tests done on the blood as well to see.
There were what?
There were no tests done on the blood to see if it was clean of virus. Or...
Oh my goodness! Oh. As far as I know, it was just cross-matched. It was just group and RH. I don't think they did anything else at the time, at all. No tests. It was the thought was that you give for every unit of blood lost, you would give a unit. Now we couldn't measure crits or anything like that, so what they did was hang up all the sponges on racks, and if there was any old blood, we then practiced. You put 20 cc's in one, and 10 in one, and 15 in one, and 5 in one, and hang it up and see how close you came to guessing how much it was. And when they hung them up, then we would count these sponges and determine whether the patient needed blood that way. One of the best things they did have labs, of course, but if you sent something down to some blood down to a lab for a crit, or couldn't do blood gases, but a crit or electrolytes, you maybe got it back in 1 or 2 hours, which was no good in the operating room situation. One of the best things that ever came out was having a lab right on the OR floor, usually run by the anesthesia department, to get these things right away. That didn't come for several years. I must point out to anybody listening, I worked all my life in teaching hospitals, so that I don't know what happened in private practice. This is all teaching hospitals. What else? I suppose not much. Oh, needles. Needles were reusable. And of course they'd get dull, so somebody sharpened them. And you'd have to look at each one to see if there was a burr on it left over from the sharpening and change it over for another one. Disposable needles were just absolutely wonderful. And disposable needles with plastic catheters in them that didn't come out were, again, one of the great advantages, I thought. There were no central lines. When they first started doing open heart surgery at Mass General, now this was, again, 58, 59, the arterial lines, they started, you could now beginning to do blood gases. Put an arterial line in was a needle. Can't remember if they were disposable or not by that time, but we put them in if we could. Needless to say, if you have a needle in a vein, it comes out quite frequently, or a vein or an artery. If you couldn't get a needle in, they did a cut down. Surgeons did a cut down. They put in a long plastic catheter, tied off the catheter in the vein, just like you do when you do experiments in animals. The distal end of the artery was tied off, and it was hoped there would be enough circulation from the ulnar that the hand didn't fall off. So much for that. Didn't medicate our patients very well, and one of the reasons I think that nitrous narcotics and muscle relaxants didn't work as well in this country as it did in England was because our patients came down to the OR not well medicated, where in England, at least the time I was there, when a patient came to the operating room, accompanied by a nurse of course, they were barely responsive. So that to add some pentothal and some nitrous and muscle relaxant to that was very easy. They also used to hyperventilate the patients. It was called the Liverpool technique, where literally, I'm sure, half of the anesthetic was hyperventilation, because once we could measure blood gases, I had somebody do it when I was ventilating a patient this way, and the CO2 was in the teens. So, you know, times change. After my residency, I went to England for 3 years and did research for most of the time, and came back. By the time I came back, there was some changes. I needed a job. I was a Canadian. I didn't have a license to practice in Massachusetts. I'd used up 3 of the possible 5 years for a temporary license, so I had 2 years to take my state boards. didn't have an anesthetic. I hadn't tried my anesthetic boards because at that time you weren't allowed to try your anesthesia boards unless you had a license to practice in the state in which you were practicing, which meant that if somebody went from Massachusetts to practice in Maine after the residency, they couldn't take their boards until they'd been in Maine for a year. So I had 3 sets of exams to write. And getting a job was not easy, but I got one at Boston University, at the old Memorial Hospital, now University Hospital. They paid me $10,000 a year, which was a good deal less than the men were making, I suspect. They said they couldn't pay me any more because I didn't have a license to practice. When I got a license to practice, then they would increase my salary. So the next year I had a license to practice. I passed my boards, or my state boards, and I had a license to practice. And so I said, okay, how about a raise? And they said, oh yes, but the budget had gone in April, and this was July, so I'd have to wait till next year. By the next July, I had my written anesthesia boards as well, and they still didn't give me a raise. The boss finally said he'd give me $2,000 of his pay, so now I was up to 12. The year later, I was boarded in anesthesia. I did pass my orals, and the answer that year when I wanted a raise was, but you and your husband make more than I do, as much as I do. So I started looking for another job. The other thing about BU was after one of the first cases I did with one of the surgeons, he said, good morning, all that sort of good stuff. And, am I married? Yes. Do you have children? Yes. How many? 3. Why do you work? And the next day, the chair of anesthesiology was working in the OR, said, Dr. X had gone to the administration about me the afternoon before. I said, oh, what'd I do? Well, he said, the surgeon had said that any woman who had 3 children at home and still worked was obviously neurotic and should not be allowed in the operating room. And he wanted me out of there. Well, I kept my job. When I started looking for a new job, there was one place in Boston that will remain nameless that apparently was down several anesthesiologists, so I got in touch with them. They wouldn't even interview me because they said they had enough women. They had one. I finally got a job at the Brigham, where my pay was raised to $22,000. So that's why I'm assuming that I was paid about half of what they were paid at BU, or what the men were paid. And I was, quote, working part-time, end quote. When I went in, Dr. Van Dam said, I'll tell you what my boys do and you tell me what you're going to do. I said, look, I have 3 children at home. I have to take them to doctors and dentists. So I need time to do that. So he said, I'll tell you what my boys do, you tell me what you do. I would do everything that they were going to do except go to surgical ground rounds that were at 5 o'clock or whatever on Thursday night, and to go to, or also surgical ground rounds, or both surgical meetings of some sort, I can't remember, but ground rounds, I guess, was Saturday morning. Anesthesia had rounds of 7, and then after that was the surgical ground rounds. I said I wouldn't stay for surgical ground rounds. The difference between me and all the men in the department was that I said I wouldn't go, and they just didn't go. But anyway, for years, I was working, quote, part-time, end quote, but I earned as much as they did. We got raises every year, and I was earning as much as they did.
Were there any other females that worked alongside you there?
In the later, I was there 10 years. In the later years, there was one other, yes, but the rest of the time there wasn't. I was one of the boys and treated as one of the boys and talked to as one of the boys, and when he said my boys, he meant me. An interesting thing happened somewhere along in that 10 years. They decided to get disability insurance for people. The disability insurance for the men, the highest they could get would pay them $300 a week. Yes, it was a week. But they couldn't get that for me. The most they would pay a woman was $100 a week. So after going through a couple of these things, they sent one of the insurance representatives in to talk to me in my office. He said, women don't work as hard as men. I'd heard about this. So I said, you have an executive secretary and the chairman of the department and one other person saying that I do. Women have babies. I said, having a baby is not a disability. Put a clause in, pregnancy doesn't count. Women have female diseases. I said, men have prostates. He blushed and left. And the upshot was that I got from 3 different companies, 3 separate disability insurance policies when men only had to have one. The other thing that happened at the Brigham was rather interesting. We wore skirts. And at the time this happened, the skirts were short, not long, and the nurses had cut off the long skirts to make the dresses nice and short. And incidentally, with explosive anesthetics, you couldn't wear slips under them because they caused sparks. And I was wearing one of these, and we had a patient who came down from the ICU. It was before that we knew that giving suction choline to somebody who'd been bedridden for a while was very dangerous. We gave suction choline, and the patient arrested. Well, okay, the tube was in, and the resident was there squeezing the bag, and this woman was very obese. I couldn't get on top of her to do CPR, so I got up on the operating table and straddled her and did my thing, got her back, and then looked up, and at the door behind me, everybody was crowded. They hadn't come in when something was working, and they just stood at the door. That was fair enough. But you see, my skirt was up around my middle, and here was my rear end sticking out at them very happily, and I was embarrassed, which is maybe why they didn't come in. But anyway, so I wrote a letter to the administration explaining that it was time that the women in ORs should wear pants. Because we were on the floor, we were up fixing the lights, we were all over the place. Because they didn't have the swishing skirts and the, quote, perineal fallout, they used to believe that a lot of the infections were caused from skin flakes falling off women's perineums. Of course, not the men's, because they wore pants. So if we wore pants, we wouldn't have to do this. Besides, it was cold in the OR, and we needed to be, by now they had air conditioning in the OR, and by now we were cold, and it would help. And in due time, I got an answer back to the effect that, Dr. Waud, you may wear what you're like, but our nurses are ladies, and they will wear skirts. We didn't wear pants, women didn't wear pants, at least any place I worked, until we came to UMass in '76. Then we wore pants. It was a good thing. While I was at BU, 2 other things happened that were rather interesting, female-wise. One was that my research was in muscle relaxants, and there was a symposium on neuromuscular blocking agents that was held in London. It was very small. There were only about 15 people internationally asked to go, and I was one of these that was asked to go. And my invitation was addressed to Professor B. Waud, and I said to my husband, I bet they think I'm a man. And the reason I thought was that because somebody had come to our lab from Montreal, and they thought that I was my husband's brother. They were surprised that I was a woman. And I said, I'll bet they think I'm a man. And Doug said, don't be ridiculous. We were publishing papers at the time with D.R. Waud and B.E. Waud, or vice versa. And so I didn't say anything. And when they said, I got a letter saying, are you traveling alone or bringing your wife? I said I was traveling alone. And off I went. And that night there was a cocktail party, long dresses, etc. And I introduced myself as Barabara Waud at the door to the person who had arranged this. He told me later that he was flabbergasted. He just didn't know where to go from there to find out who B. Waud was. And the people in the States that had gone didn't know which Waud it was because it just came out as Waud. And they assumed it was Doug, my husband. We did research together. So I walked around and was met by somebody who told me all the things around the meeting hall that I could see when I was there. And I said, well, that was rather interesting, but I thought I'd go to the meetings. And he said, good Lord, you don't take this seriously, do you? And disappeared. I never saw him again. Then one of the guys came up to me when we were in the food line and said, everybody's wondering where B.E. Waud is. They assume you're his wife. And he said it just occurred to him that I was B.E. Waud. He was a Scottish fellow, pharmacologist, and he said he has a letter, which I now have, that when he was asked, he wrote and said how nice it would be to see Doug Waud again. And the letter going back was, oh, we're keeping this thing clinical. We're asking his brother. He said, I didn't think Doug had a brother. So there it was. One of the older members there came up to me and said, it's all right, Barbara, I'll help you with the arithmetic. I knew more calculus than all the rest of them put together. And that made me proof it at the meeting. You know, that was enough. My name was made.
Were people there, did they stick up for you at all?
It wasn't a matter of sticking up for. Who was sticking up for me? What sticking up was there to do? They were Europeans were surprised I was a woman, but that was all. The Americans were surprised I was me and not my husband. And other than one guy saying he'd help me with the arithmetic, when everything we were discussing was kinetics and calculus and all that sort of stuff, which I knew more than any of the others. No, I held my own. I thank you very much.
Well, I mean, stood up for you as far as saying this is foolish, you should be allowed to go to the meetings, since everyone gave you such a hard time about attending certain sections.
No, the only person who said anything was somebody who thought I was B. Waud's wife. And he was trying to be nice to me and tell me what I could see. Not that I couldn't go to the meetings. He just assumed that I was a wife, and he was helping me, telling me where Buckingham Palace was and all those things. And never mind that I'd lived in Oxford for years and knew all that. No, he was being nice to me
So
as a wife. He had no idea that I was a vision. Certainly not one of the elected 15 people who were there. And it was great because the last night we had a formal cocktail party as well at one of the houses, and there were people down on their hands and knees drawing pictures on their living room rug. It was a good meeting. It was a really good meeting. But no, calculus came in handy. I held my own, thank you very much. And from then on, everybody knew I was a woman. The other thing that happened when I was at the Brigham, I was asked to be on an advisory committee for the FDA on anesthetic and respiratory drugs. And what they would do is, if there was a new drug or any problem, they would send us out all the information, and we would read up on it, make a report, and off we would go once every month or two, depending on how often they needed us, to Washington to have a meeting. They put us up in a hotel in Bethesda. And the first time I went there, I got there after work, about 7 o'clock at night, and I went down to the dining room, and I wasn't allowed entrance. We don't allow single females in our dining room. Do they have room service? No, they don't have room service. Is there a restaurant nearby that I could go to? Well, there's an Italian one a couple blocks down the street. Is it safe to walk there? No, I'd have to take a taxi. Would they let me in when I got there? No, probably not. They didn't know. So, I mean, in those days, single women only went into dining rooms for one reason, and it sure wasn't to eat, you know. So anyway, I complained to the FDA, and they didn't get it. What he said was, we're not allowed to fraternize. I'd love to take you out for dinner, but we're not allowed to fraternize with people on our committees. I said, I don't want them to take me out for dinner. I just want to be able to eat in the hotel in which they put me. So the next time we went, yes, I could eat in the dining room. So down I went to the dining room, complete with a book, and they put me back in the corner. I won the battle, they won the war, because it took me all night to eat. You know, they just sort of ignored me most of the night. After that, I took peanuts and chocolate bars. And the same was true if you went to meetings. When I went to meetings, there weren't women going, and where would you eat? Coffee shops, perhaps, but that was it. Well, I wasn't on any committees at the Brigham, any hospital committees at the Brigham until, mid-70s, when it became the done thing to have women on committees. I could be on any committee I wanted. Never mind, I didn't know anything about it. And that carried on even up when I came to UMass, where I was invited to be on a committee. They were setting up a professorship at Mass General, and my invitation was, Barbara, we need a woman, and they say you're as good as any. Now, for that, I was supposed to, they had noontime meetings. I was supposed to drive from here to the Mass General, try to get a parking place, go to an hour meeting, drive back, because I was a woman. So I refused. Same thing happened at UMass. They were taking somebody was applying for the chairmanship of anesthesiology, and they were taking him out to dinner, and it suddenly occurred to them they didn't have a woman. So at 5 o'clock on the night they were going out for dinner, somebody came out to my office and said, Barbara, we need a woman on. You come for dinner. I didn't go there either. You know, you don't go places because you're a woman, and you'll do. At least I didn't. They had surgical conferences at the Brigham, and every new faculty person and anesthesiologist was asked to go down and talk, except me. Never, and on the 10 years I was there, was I ever asked for one of these, in spite of the fact that more research came out of off my desk than all of the others put together. I was the only one at the time doing original research, and I didn't get asked. Everybody else did. But eventually I could get on the committees. How many have we taken too much time?
No, not at all. We have about 20 minutes.
We've only been talking 20 minutes?
No, we have about 20 minutes left.
Oh, well. In '76, I came out to UMass. When my husband came out, had been commuting from Newton from the time that the medical school opened. And when they opened the hospital in '76, I applied for and got a job here, and I came out here, and we moved out here. I've been here ever since. At the time I came, there were 2 other anesthesiologists plus myself. We did maybe 1 or 2 cases a day. Call, well, maybe an appendectomy now and then, but not very much. And it gradually, as the hospital opened, they opened more beds. There was a strange thing that happened. If you stayed in the hospital overnight, some of the residents, we didn't have anesthesia residents at the time, but other residents did, they were given a patient's room or whatever, whatever was available. But if you got up at the night and had to go to the bathroom, you had to take your pillow with you, because when you came back, it was gone. And I gathered that the bedding, sheets, and pillows and everything were stolen en masse at the time it opened, so that things have changed, perhaps. I don't know how much is stolen now. I know I think it was the anatomy department had all their microscopes wiped out at one stage of the game.
Who was stealing them? People were just coming into the hospital and taking them, or staff?
I don't know who's stealing them. I have no idea who is stealing them. You still have to lock up everything, and I don't know whether it's people who work here or people who just come in. When I started here, you stayed at home, and if there was something, a cardiac arrest or something, you came in from home to do CPR. I came in one day, I came dashing in, came in the medical school door, because that was the one that was open, went dashing through, and some guy sitting at the desk said, "Hey, come back." I said, "I'm going to a cardiac arrest in ICU. I'm a doctor. It doesn't matter, get back here." And I kept going, and he pulled out a gun. So I went back, and I stood in line. He wouldn't even let me at the head of the line. Other people there checking in were medical students, and I was at the end of the line, and I got up there. I mean, it was silly anyway. If by the time you come in 15 or 20 minutes for something like that, the patient's either better or dead, yeah. So I got up and said, "What do you do?" And they said, "Well, you park in the emergency ward." That's how you get in the hospital at night. Sometimes when you came in for one of these to the ICU, they didn't even know why they'd called you. Maybe somebody had arrhythmias and they sent out a call. And most of the time it was ridiculous. And was several months or maybe a year before they had residents on call, staying on call in the hospital. And that is one of the big changes, I think. When I started my residency, the attendings went home at somewhere between 3 and 5, and the operating rooms were run by the residents, surgical and anesthesia. The first call, we had 3 anesthesia residents and 1 student anesthetic nurse on call every day. The first call resident acted like the staff person did during the day, like supervised things, and the others did the cases. But the staff, if you had a problem, you could call your attending. Sometimes the surgical attendings came in if it was a private patient, but the anesthesia ones didn't unless it was a VIP. That we did it all. By the time I was at BU, and that was 3 years later, 4 years later, and also at the Brigham, the anesthesia attending was called for every case. And then you decided whether you would go in or not, depending on the case. And I can remember once, it was a relatively simple case, and the resident said, please come in. This was while I was at BU. He said, I can handle the patient, but I can't handle the surgeon. So I went in for that. Now at UMass, and I think all of the time I was here, as far as I remember, the attending anesthesiologist comes in for every case, even if it's a local. At the time I started being faculty, you started one morning at 7, and you got out when your cases were done the next day. So if you worked all night, it was too bad. Usually you got an hour or so sleep, which isn't much. But also usually some friend of yours took over your rooms that you were supervising. You got the cases started, they take over the cases. You signed your name to it, they followed them, and you could get out by noon or so, but that was 30 hours still. And that was the way it was when I came here. Then they changed to the on-call faculty person leaving at 7 o'clock the next morning, so that was only 24 hours. By the time I left, the call person was coming in at 3 o'clock in the afternoon and leaving in the morning. The residents on call at the Brigham, the on-call resident didn't go home the next day, but did all the stuff around the wards for any time anybody called, so they could get some sleep. Here, I believe from the time we started, the resident went home, but I can't remember that. Certainly they do now. And yes, we do tougher cases now, but you know, if you're up 24 hours, you're up 24 hours. And sometimes it's easier to do something that keeps you awake than it is to just sit there. Is there anything duller than sitting there with your hand on a bag, with the patient breathing, when you haven't been to bed for 24 hours? My husband used to practice just as I was going to sleep, holding his breath. He said I woke up just like that, because it was hopefully second nature that you wouldn't fall too much asleep during this. It's easier to have something to do than it is just to sit there inhaling all this ether or whatever.
There's a few questions I want to make sure I get in, since we only have 10 minutes. I wanted to ask you what sort of advice you would have for a young physician just beginning to enter into medicine.
Take something else. No. I don't know that I have any advice. I think people go into medicine for very different reasons, and somebody's not going to talk you out of it. If you know, I did when my daughter thought she'd like to go into medicine. She was in high school. I suggested that she take other things and think about other things, not medicine, not because she wouldn't be good at it or couldn't do it, but because this is all she knew. Her parents were both doctors, and and her grandfather was a doctor, and this was all she knew. To try something else. You can't talk somebody out of it if they want to do it. If you can talk them out of it, then they shouldn't be there in the first place. You know, it was interesting being a doctor in the family, female. When I first started, my one daughter came home one day and said, when she tells people that I'm a doctor, they don't believe it. So now she tells them I'm a doctor, and that's just like a nurse, you know. And the other time, the Campfire Girls were having an overnight hike, and they needed a nurse, and none of the mothers was a nurse, but my daughter informed me that they said I could go instead of a nurse. So I went. But I don't have any advice for them. You do what you have to do. And you either like it or you don't like it. If you don't like it, you get out. If you like it, then that's your calling and that's what you do. Success in this world is waking up in the morning and wanting to go to work, and it doesn't matter what that work is. If you hate going to work, no matter what your income is, that's no way to live. Especially in medicine where you're working 60 to 80-hour weeks for half your life. Okay, next question?
Your family. What do you think it was like for them? What do you think it was like for your daughters to have such busy parents?
To have such what?
Such busy parents. What do you think it was like for them growing up?
The time that we were home were theirs, belonged to them. We did things, we didn't go out at night, and we did things with them on the weekends. And they didn't suffer. They're great kids. My daughter did tell me when she was about 15, and we were discussing women working, that she thought it was a good idea it worked. Because if I stayed at home all the time, she'd hate me more than she already did. And then she said, but you know what I mean by that. Well, yeah, I did. And she's the one who's now working. Both of them are working. But she's the one who's now the physician. They did well. They learned to get their homework done because it was expected. They learned to get to their piano lessons and all of that by themselves because it was expected. Mom and Dad couldn't join carpools. We weren't home. So they did it on their own, and they did it well. They became very self-sufficient. And they turned out well. But nights and weekends were theirs. Their father got home more often than I did. I sometimes worked all night, but their dad was home. And it worked well. We had live-in people, housekeepers, until we came to UMass, and then we had somebody come in every day. They never went home to an empty house. Near their end of their high school days, of course, they were almost the same age as their babysitters, but they never went home to an empty house. There was always somebody there for them. There were no daycare centers.
Yeah. What was your involvement when you were working at UMass as far as teaching goes?
Well, we taught residents. I gave the lectures for many years in the pharmacology course. I gave the anesthetic lectures. That was it. You were in the ER. What we had, most of the cases were either done by nurse anesthetists or by residents. You taught the residents. Yeah, they have lectures almost every day. You'd have to give those. They have seminars, all that sort of thing. You do that. One of the big differences since coming to UMass is that patients used to be admitted to the hospital the night before surgery, so you did rounds the night before and saw your patients and knew them and knew their charts. And then you saw them post-op and find out problems that they might have had. Can't do that anymore. They come in, even heart patients come in the day of surgery. They had a pre-admission testing group down there, and now it just got so busy that it was a farce. You couldn't spend enough time with patients. So the healthy patients come in the day of, and you see them first when they're ready, getting them ready to go to the operating room. So you don't know anything about them, really. And you don't see them afterwards to know if they have any complaints. It's an assembly line. And I think that's bad. It's bad patient care, and it's certainly not it's not as pleasant for the anesthesiologist not to know anything about your patients. You know, it's one of the real big things at the HMO and the push for the bottom line. The other thing is that surgery was supposed to end at 3 when I started. It didn't ever. Surgeons were always late, but then it was 5, and then it was 7, and now I hear that they can schedule cases till 9 o'clock at night. That's a long day. Without the ability, quite often, to hire the staff to run shifts. There's a shortage of anesthesiologists still. Or again, I should say, a few years ago there were too many and everybody stopped taking anesthesia residencies. Well, they overdid it and now there's a shortage again. So that there just isn't enough people or enough money to run shifts. I don't know what it's like now with the merger, but certainly we were paid a salary, And the money that the anesthesia department went to the group practice and the dean's fund, and we were paid a salary no matter what we did. You weren't paid at that time for overtime or any of the rest of it. You just went in and you worked until you were finished and you came out. If there is no money, you're not going to hire more people on a salary to do the cases when somebody who's only worked 12 hours can do them. Huh? That's bad. The residents go home early now. Their hours, last I heard, were limited. I don't know to what a week, but now they go home. And the staff people who've been teaching these residents all day then take over the case and finish them. And that's not good for a residency program either, because the anesthesia is like flying a plane. The interesting parts are the beginning and the end. The middle, you could be on autopilot and it would be fine. And the residents are missing many times the ends of cases. Anyway, more questions?
They're limited to 80 hours a week, I think.
Is that what it is?
Yeah.
Is it that much? Oh my goodness. Okay.
Let's see, what other questions? It amazes me how much prejudice there was when you first started medicine. Really to think how far along we've come, but I think how far we need to go.
Oh yeah.
Next year's entering class at UMass, there's going to be 60 females, 40 males.
Really?
Yeah. So I think we've come a long way. I just wonder if you have any comments on how far we have come over the years.
Well, the other thing with women, I don't think I mentioned it, was I was at a meeting, I was giving a lecture for a refresher course on the West Coast, and went to pay my hotel bill, and wanted to give them a check. It was Holiday Inn, and they no longer took checks. They always had taken my check before, so I ended up visiting the manager. So what am I going to do? You used to take my check, now you won't take my check. And he said, well, they've stopped that. Too many people closed out their accounts before the checks could be cashed, especially on the weekend, and this was Saturday noon. He said, credit card. I pointed out I couldn't get a credit card. I was a married woman. They didn't give credit cards to married women. My husband had refused to get credit cards for a reason I don't know, and I couldn't get one. So he took my check, and I went home and told my husband he better get a credit card pretty soon, because I wasn't going through that again. But yes, it's very interesting.
So what do you think of all the changes that have occurred, even the changes that you've seen throughout your career? I'm sure you've seen.
Oh, they're great. They're great. Certainly, there are having more women around makes a lot of things, a lot of problems I had more difficult. I can now get into a hotel restaurant, for example, with no problem. And when you go to meetings, there are other women to have dinner without being accused of trying to steal somebody's husband, you know, that sort of